like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. And I'm right where I belong in my happy place. And I'm right where I belong in my happy place.
Hi, welcome to the National University of Singapore Yongloo Lin School of Medicine's Healthy Longevity webinar. I'm coming to you live from Maine tonight, where we have a Gordon conference on systems biology of aging. So I'm finding a lot of new speakers here. We're lucky tonight, though, to have Dr. John Beard, and we'll be coming back to him in a minute. I want to remind you to use the Q&A function to ask questions. I'm sure you'll have a lot of questions tonight. Today, before we start with John, we have Shivanisha Ravamtharan, a research assistant in the Center for Healthy Longevity, and she'll be talking about cardiomyocyte senescence and ER stress.
Thank you for the introduction. As mentioned, my name is Shiva and I'm a research assistant in the Center for Healthy Longevity. And today I will be presenting a paper on the function of the PCSK6 enzyme in modulating senescence in cardiomyocytes. Cardiac aging can lead to many different issues, such as thickening of heart muscles, cell death, and inflammation, that ultimately leads to the onset of cardiovascular diseases. Heart muscle cells, such as cardiomyocytes, are reduced in numbers with age, and the number of cells that become senescent are increased, eventually negatively impacting cardiac function. The enzyme PCSK6 has been implicated in maintaining cardiac function downstream of the natriuretic peptide system. Researchers first looked into the protein expression of PCSK6 in the hearts of aged mice compared to young mice. They found that the expression of the protein was reduced in the aged mice. They also looked into the protein expression of P21 and P16, both of which are markers of senescence. These were found to be increased in aged mice compared to young mice, indicating higher levels of senescence with aging. These were repeated in H9C2 cells. The cells were treated with D-galactose, which induces senescence, and 3 markers of senescence were looked at. These were beta-galactosidase, P16, and P21. There was increased beta-galactosidase with induced senescence, which can be seen from the increase in blue staining. Similar to the aged mouse models, there was also an increase in the expression of P16 and P21 and a decrease in the expression of PCSK6. Next, researchers found a link between the PCSK6 enzyme and senescence in cardiomyocytes. To do this, they knocked down PCSK6 enzyme expression in the H9C2 cells using siRNA. In cells with reduced PCSK6 enzyme levels, there was found to be an increase in P21 and P16 expression, indicating increased senescence. To see if this translated to negatively affecting the cardiomyocyte function, researchers looked at AGE and ROS levels. AGEs are advanced glycation end products that include proteins and lipids which become glycated when exposed to sugars. These are biomarkers that are implicated in aging and were increased in PCSK6 knockdown cells. ROS, or reactive oxygen species, cause oxidative stress and are also implicated in aging. Similarly, levels of ROS were also increased, and overall there was increased cell death via apoptosis. Next, researchers increased the expression of PCSK6 enzyme in cells and treated them with D-galactose to induce senescence. This was to find out if the increase in PCSK6 would decrease the markers of senescence. They found that there was decreased expression of P16 and P21, and less of the cells were positive for beta-galactosidase. There was also a decrease in ROS levels, indicating that PCSK6 was also able to rescue dysfunction of the cardiomyocytes when treated with DGAL. Researchers then conducted RNA sequencing on cells that were knocked down for the PCSK6 enzyme to find changes in the signaling pathways. They found that there were changes in the protein folding process in the endoplasmic reticulum of these cells, and found that there was upregulation of DDIT3 gene expression. DDIT3 is an ER stress marker, and its upregulation might indicate that PCSK6 could be linked to ER stress and protein homeostasis. Researchers found that in PCSK6 knockdown cells, there were increased DDIT3 positive cells and mRNA expression. And in aged mice, the levels of DDIT3 protein were increased in the hearts compared to younger mice. H9C2 cells that were either knocked down or overexpressed with PCSK6 enzyme were treated with tunicamycin, which induces ER stress. In cells knocked down for PCSK6, there was high expression of DDIT3, and in cells overexpressed with PCSK6, there was a lowered expression of DDIT3, indicating that PCSK6 does regulate DDIT3 expression in cardiomyocytes. In conclusion, researchers found that the PCSK6 enzyme does modulate senescence and impairs functions of cardiomyocytes in the heart when reduced with aging. They've also found a link between the reduction of the enzyme and increase of DDIT3, an ER stress marker, indicating that as PCSK6 levels reduces with age, cardiomyocytes may become more vulnerable to ER stress. Thank you very much.
Thanks, Shiva. So moving on to John Beard. John is a professor with the Center of Excellence in Population Aging Research at the University of New South Wales. From 2009 to 2019, he was the Director of Aging and Life Course with the World Health Organization in Geneva, where he led major global initiatives, including the World Report on Aging and Health and the Global Network of Age-Friendly Cities and Communities. He's also worked extensively with the World Economic Forum. His special interest is in rethinking what health is for people in the second half of life. The topic of his talk today is very futuristic, beyond the absence of disease. Thanks a lot for coming on the show, John.
Thanks, Brian, and it's great to be here. You've used the word health a lot in that introduction, and we use it every day. And often when we use it, we tend to frame it from the perspective of the absence of disease. The WHO Constitution, actually from 1949, framed health as more than the absence of disease, but a complete state of physical and mental well-being. But I have to say that that definition has been very poorly operationalized since, and we continue within health systems and within WHO itself to still think of health very much from the perspective of disease and its presence or absence. And what I'm going to do is try and paint a different way of thinking about health, and one where I think we're at a very critical juncture in history, where for the first time we might be able to monitor health much more directly, and that has very significant implications for healthcare, for research, and for the way we think about our own lives. So I'm going to try and take you through a little bit of the journey that I went through to get to this point of thinking, and explain a little bit about WHO's thinking about healthy aging, which is my own background, and then I'll end with trying to explain why I think it's such an important point in the history of medicine and health care. So here you can see again the title of my talk. Now, why is it so problematic to think of health from the paradigm of the absence of disease? Well, first of all, if you think about our health systems as they're currently structured, they are very disease-based, and they often developed from acute care models which were designed to identify a disease or an injury and to cure it. You know, somebody has a broken leg, they go to hospital, they get sent home, and hopefully they get on with their lives. But the problem is that as populations have aged, the dominant burden of disease is now due to chronic diseases. And most people over the age of 65 actually have more than one chronic disease at the same time. They have multi-morbidities. And our health systems haven't been so well designed to manage chronic multi-morbidities or to deliver the ongoing care that's needed to minimize the subsequent impact of those conditions. And as a consequence, one of the things we've developed within health systems is very disease-based clinical silos. We could say the same about research. People tend to operate very much within their own silo of expertise. There's very poor vertical or horizontal integration. So despite multimorbidity, you might go to one specialist, then the next specialist, and then the next specialist, but there's very rarely the ongoing coordination of those services. And finally, we tend to think about a disease, and we deliver a generic response to that disease, regardless of the variation that might be present in that individual that might be being treated. Another challenge was thinking about using disease as the basis for the way we frame health is, as populations have aged, one of the key questions has been, as people are living longer, are they experiencing better health than generations in the past? And I have to say, the research to answer that question has been very challenging. It's challenging because of the data we've got, but also of the way we frame the question. And for example, in the US, we see that over the last 20 or 30 years, there are increases in the prevalence of major diseases such as cancer, stroke, and diabetes. But there's a delay in incidence and reduced prevalence of myocardial infarction, and also delays in cognitive decline. And at the same time, we're seeing reductions in high-risk cardiovascular risk factors such as hypertension and cholesterol. So we're seeing better control, but we're not seeing a lower incidence. So people are getting hypertension and high cholesterol as much as they did in the past, but the control has been better. And what all that adds up to when you try and tease through it is that there has been very little change in underlying biology. We've got better control of disease risk factors. We've got reduced mortality from heart disease, and we've got longer survival with other conditions. And what that means is, if people who had previously would have died when they were 60 live till they're 70, they're likely to be living with the condition that would have killed them, but we're treating it better, but they've still got the condition. And so we see an increasing prevalence of disease in older age groups. It's all very hard to sort of tease through and understand exactly what's going on. To give you a feel for what that adds up to, another way of looking at it based on disease is health-adjusted life expectancy. So what we've found is that the gap between healthy life expectancy and life expectancy has actually increased over the last 20 or 30 years rather than decreased, which is what we would have hoped for. As people are living longer, that they'd live longer and healthier. So I'm afraid that 70 is really not the new 60 just yet, but I do think it could be. And I think to get to that position, we need to rethink the way we frame our very thinking about health and the biological changes that occur beneath it. Another problem with the disease-based paradigm is that we often frame vulnerability on the basis of age. We think crudely, do people have disease, or what age are they? And so when we had the pandemic, or while we're still going through it, we think of older people as being high at risk. But in fact, it's probably not age that is the risk factor for people from COVID. It's probably a whole range of underlying physiologic changes that make them more vulnerable. And if we don't think about those underlying changes and don't attempt to measure them in individuals, we have to fall back on these crude ways of categorizing them. The next step from that is we tend to stereotype people, and we talk about the elderly, often again defined by chronological age. So people over the age of 65 are elderly. But what I'll show you in a moment is that, in fact, older age is a period of incredible diversity, and you can't just put everybody in a box and say they're the same. And then a final consequence of that is that we tend to, throughout society, have a very pervasive ageist attitude, so that we think that older people are something, and then our society treats them in that way, and sometimes is biased against them in that way. And then older people themselves can internalize those ideas and think about, well, that's how I should be living my life as an older person. And there's quite good evidence that if you internalize negative ideas of what it is to be an older person, it has very significant negative consequences in terms of your health and life expectancy. So what exactly might health be? What's an alternative to thinking about disease? Well, first of all, think about older people themselves. What they report, regardless of how many diseases they have, is they can report on their health state. And often people with multiple conditions say they're still healthy, essentially because they can still do things. Another sort of interesting twist on this is the example of metformin, which is a drug which is used to treat diabetes. What people found was that in clinical trials looking at the effectiveness of metformin, people who had diabetes and were treated with metformin actually tended to live longer than people who didn't have diabetes, which is a bit strange if you're talking about health. Who's healthier, somebody with the disease and who's treated, or somebody who doesn't have the disease? And then finally, as we try and frame this question, we have to understand that particularly in the last years of life, people can experience functional declines in the absence of disease. And so just older age can lead to people becoming frail and having very limited function towards the end of their lives. So all of this sort of thinking, all of this research led us in 2015 to try and reframe health, which we spelt out in a document called the World Report on Aging and Health, which is available on the web and you can download it. And it's been very influential. It's been downloaded over 1 million times. And in that report, we tried to reframe the idea of what healthy aging might be as saying it's the process of developing and maintaining the functional ability that enables well-being in older age. And we said that functional ability was the ability to be and to do the things that you value. So if you can do the things you value, that's really was our ultimate definition of health. And we said that was made up of a number of things. The first is the individual and all the internal attributes of the individual that may enable them to do those things. The second is the environment that they live in. So, for example, I need to sit to give this talk. To do that, I need a chair. So the environment is important, whether I can do the things that I want. And there's also an interaction between the individual and the environment. The environment is not neutral in the way it relates to somebody, but that's very dependent on things such as their race, their age, their sex, and so on. So what are the things that people want to be and do? In the report, what we said was that there are at least 5 key things which are important. The first is everybody wants to have their basic needs met. They need to have somewhere safe to live. They need to be able to get out. They need access to healthy food. They need basically to live in a secure environment. Older people also report that no matter how old they are, they want to continue to learn, grow, and particularly to make decisions for themselves. They don't want other people making decisions for them. Older people need to be able to get where they need to go to do the things they want to do, so they need to be mobile. Older people also report even more than younger people, the importance of building and maintaining relationships. And also older people want to contribute and to be acknowledged, to be seen as individuals. So these are the higher level things that older people want. At an individual level, though, and this is probably what people talk about more when we talk about health, at an individual level, how can we frame the way we think about all those individual level attributes that might contribute to this ability. And in the report, what we used was this term intrinsic capacity to describe all of those individual level attributes. And this, on this figure, which is really just a schematic, but it's looking at the second half of life, what you can see at different age groups is the range of intrinsic capacity, which is typical in those age groups. So you see at younger age groups, people have higher capacity, and then as life goes on, there's a general tendency for it to decline. But the other thing you also see in this figure is that the range increases. And that's really important. So in midlife, at the start of this curve, there's a fairly narrow range. People, generally have fairly similar health status. But as people age, that range gets much wider. So you have some people, and people in their 80s and older can retain the robust health of a 20-year-old, while people at much younger ages can actually have very significant losses of function. And that's why it's really important not to think of a typical older person, because you see, if you talk about everybody who's 65 and above, you can see the incredible diversity that might be present within that group. So it would be much better if somehow we could point directly at where people sit on these ranges to identify their vulnerabilities, their strengths, and how they might respond to specific interventions. So since I left WHO, what I've been spending a lot of time doing is thinking about how we might actually think about this constructive and intrinsic capacity and how we might measure it, and then how we might use it, and is it useful? And so if what we did was to start from this idea that it's all the individual level attributes that contribute to functional ability. And we used two very large and very well-established longitudinal studies. The English longitudinal study on aging, and you can see all how many participants were involved, and the China Health and Retirement longitudinal study, Charles. And we looked within those cohorts at all the possible data that was available on somebody's capacity, or anything that related to what might be inside their skin. And we then looked to see, first of all, does that measure of capacity which we constructed, is it useful? Does it predict outcomes? And what we found for both studies, incredibly similar findings, which reinforce the fact that this is probably quite robust research. What we found was, yes, indeed. And if you look at this figure, the top figure is for the English longitudinal study, and the bottom figure is for the China study. And what we're looking at here is we're looking longitudinally at people. And we're looking to see if people who had no loss of function actually ended up losing what are called instrumental activities of daily living. We did the same with activities of daily living, and both of them are quite severe losses of function. And what you can see from the figure is, after taking account of all the characteristics on the left, their sex, their age, their education level, their wealth, and the number of multimorbidities they had, intrinsic capacity had a very powerful relationship, a predictive relationship, with whether people would subsequently lose function and become care dependent. What you see in the ELSA study is almost the entire effect of multi-morbidity of the diseases actually operated through its effect on intrinsic capacity. And what you see in the bottom figure is that both the number of diseases and intrinsic capacity influence the outcome. But what this tells us is that this construct of intrinsic capacity is a powerful predictor of subsequent outcomes, and that it adds a lot of information to the normal clinical assessment, which would look at the amount of multi-morbidity, people's age and sex and so on. And so it seemed, first of all, that it was a useful thing to pursue. The next thing we looked at is how this construct might be framed. And I told you that we drew on all the characteristics which were available in both these studies, and we did what's called factor analysis to see how these clumped together. And interestingly, for both studies, the results were identical. They clumped into 5 different subdomains of capacity: cognitive capacity, sensory capacity, locomotor capacity, a thing we called vitality, which I'll talk about in a moment, and psychological capacity. And all the all those relationships were statistically significant. So this is quite a robust construct. It seems to powerfully predict the future, and we can think about how it might be built up without thinking about disease. We then tried to take that a little bit further and say, well, how does that actually come together? Again, some of these things seem to be at a different level. What is this thing called vitality, for example, which, if I went into the details of the previous analysis, you'd see it's very much based on biological sort of characteristics and tests. And this is the model that we came up with thinking about how you might construct and how you might measure intrinsic capacity, and how, in a sense, you might think about somebody's health, because intrinsic capacity really is just a surrogate for somebody's health, or excluding all the environmental determinants that might help you achieve what you want to do. And so what this construct shows is that if you think about all the individual things that might be part of somebody's health, you start with your genes, with your genetic inheritance. And then within the body, and what we see happening as people age, and this is the area where geroscience is starting to explore things in much more depth. You can see all these underlying changes which occur, and which ultimately all add up to higher level physiologic changes, and ultimately become expressed in these different capacities which I've put at the top, that I spoke about before: locomotor, cognitive, sensory, psychological, and we added other because there was probably some things we couldn't measure. But all this stuff below, which is unseen and happening and changing as we age, and again, is the domain of geroscience, we call that vitality. And so you have two lots of characteristics. Some of them are expressed, the ones at the top, and some of them that you don't see, but which are still changing, which are still happening inside each individual, and they're at the bottom. Now, the interesting thing about framing things in this way is that as geroscientists have tried to look at interventions to target some of these characteristics at the bottom, the physiologic characteristics that are changing as we get older, often they're forced to test them against whether people develop disease or not, because it's very difficult to think about, well, how do they impact on people's health? And yet I think what this frame does is give us another way of thinking about how we could test them. So, for example, if cellular senescence, and we heard the talk previously about senescence of cardiac cells, if we can find an intervention to target cellular senescence, how would you know whether it was working or not? You might look at the cells, but traditionally we would have had to wait whether they had heart attacks or heart failure. If you think about this way of framing things, however, you can monitor in a day-to-day way continuously people's state of functioning, and continuously monitoring those things at the top. And so you would find that cellular senescence has an impact on those expressions of health much earlier than if we were waiting for disease. And so it becomes, I think, a useful way of, a useful outcome that we can use in research for some of these underlying characteristics. The other thing, if you think about geroscience, the whole principle is that those things that are occurring below, the things in green, they don't have an impact in terms of a silo. So immune function and some of the pro-inflammatory changes we see with aging doesn't just affect heart disease, for example. It affects cardiovascular disease more broadly. It may even affect cognitive function. And so all of those things below are acting in multiple ways, not in a siloed way with a specific disease. And we need to understand the impact they're having, the broader impacts they're having on people's functioning and well-being. So, and this is where I said I would try to tell you why I think this is important and how this might be applied. first of all, I think as we consider geroscience and other research, this provides a very different outcome that we might be thinking about. It provides an outcome that's continuous. It provides an outcome that changes on a day-to-day basis. And so we might be able to detect changes much more early and much smaller changes than we would be able to detect if we were relying on disease as an outcome. As I said before, what the initial research showed is that this actually adds clinically valuable information. And there is the potential that that might lead to more integrated care. There is a program called Integrated Care for Older People that WHO runs. And basically, it's using this principle that you consider somebody's capacity, and rather than starting with disease as the initial assessment, and that then ultimately leads to much more integrated and cohesive care. And then you can use these, again, as an outcome in which to assess the impact of the clinical interventions that you put in place. And for example, you could be quite radical and think about, well, instead of funding throughput at hospitals, we could actually fund health services in terms of the impact they have on people's capacity. And no matter what intervention they do, for what condition it is, what's the way that they can have the biggest impact on people's health? This is also the way the body works. You know, when we talk about disease and think about disease, we're going way back to Hippocrates and the Greeks, and these were the obvious things, and that was the way they framed thinking about health. We're now at the point where we can actually assess much more subtle changes that are happening within people. And by doing that, I think it will enable us to pose much more radical research questions and come up with some really transformative interventions. And finally, with all the mega data that's out there and the data which we can collect on us as individuals, the monitoring devices that are in place, all the biological testing that's done, we're at a point now where we can use machine learning to try and pull all that together and point much more directly at what a person's health is. No longer try to assess their health through the lens of disease, but look directly at them, because that's the way we're constructed. And I think we're just at that critical point now where we can start to do it. But to achieve that, we need to be able to conceptually frame this in a way that's meaningful and that will work. So I've tried to be provocative, and well, Brian, I look forward to having a chat about your thoughts on some of this.
No, I mean, I think it's fascinating. You know, we're really at a point where we have all these interventions that we think are likely to improve people's health with age, and looking at functional capacities and as an endpoint, I think, is a very interesting way of going about it. We're struggling. I mean, if you do disease prevention, you know, you're talking about multi-year, studies with large numbers of people, and it costs a lot of money. There are new aging biomarkers that have come about that we're using, but they're not fully validated yet. So I think something in this approach where you're actually looking at the capacity of individuals, and I think the challenge is, how do you generate metrics for that are reliable enough and not that noisy, so we can actually use them as clinical endpoints. So, you talked about self-expressed capacity. I mean, is that what you're thinking, or what are the metrics that would be ideal for this?
Okay, well, I didn't go into details because we were limited for time. But no, it's not. This is for things like psychological capacity, it really has to be self-reported because you can't test that. But for things like locomotor capacity, there are a range of simple tests you can do, and physical performance batteries which test like chair rise and gait speed, things like that. For cognitive function, there are some very traditional cognitive function tests, and for underlying vitality, it's interesting. I think there's two things which came. Well, one thing that came out of our analysis was that grip strength was fell into that group of changes, and was much more tightly than it fell into locomotor. So I think something like grip strength may be a proximal measure which we could use to assess the impact of some of the geroscience interventions which are developed. I also think a useful one in that domain is actually waist circumference, because looking at people's central adiposity and the impacts that has on inflammation, because it's pro-inflammatory, the more central adiposity you have, I think that might be a useful marker as well. So no, there are definitely quantitative markers which we can monitor, and I think the problem with most of the biomarkers which we've looked at to date, they tend to be validated against chronological age, and we are falling back into the trap we're trying to get away from. So I think we need to have something different, and framing it from the perspective of functioning is much more logical, but you need to pull it together in a way that makes sense.
Yeah, I mean, we're doing a lot of those individual assays in our clinical studies, and I think that a challenge is how do we put it together into, and integrate it, as you just said. But one thing we can do is we can correlate a lot of these things to our aging biomarkers as well. So I think it may take some sort of holistic approach to put together many different kinds of ways to measure aging. When you were talking, we talk a lot about how the medicine does sick care and not enough health care. And you were mentioning that, but I think that one thing that struck me is it's really a window of time that we treat people in really well, right? There's this whole period of time when they grow up and they get older, but they're not sick yet. And preventative care, depending on where you are, is not very good. We don't really take a life course approach to health. And then there's the period of time when you get a disease or two, and we have gotten much better at treating that. But then there's another window at the end with multimorbidity and frailty. And I feel like, that good, effective treatment for that is just eluded us. When you start putting multiple diseases together and people taking lots of different kinds of pills, it seems like there's a big gap in understanding on that end as well. So it feels like we're really good in about a 15-year window at medicine, but the rest of the life we're not doing much with.
I think geriatricians are pretty good on that last stage of life. Yeah. And I actually think perhaps we'd do well to think about taking the geriatric paradigm and applying it across earlier stages in life. So geriatricians tend to think about the person as a whole and tend to work with the person and try and help them achieve, their aspirations. If we, for example, monitored capacity across the second half of life and saw where people sat against population norms, what their trajectories were like against population norms, we would be able to extend that much earlier in life. And that's actually very similar to what we do with pediatrics. In pediatrics, we look at functional development, basically, and measure that in different ways. And we see whether people are veering off a population trajectory. We don't wait for the disease to come in. We monitor their functioning, and then we think about why it might be veering off normal. I think we should be thinking about that across the whole second half of life. And as we are more able with monitoring devices and things like that to constantly monitor people's health state, we should be able to monitor those population norms much more accurately and say to somebody, hey, look, you might be only 45, but the trajectory of your health means that, when you get to 70, you're going to have much poorer health than somebody else. And, here's some things we could be thinking about it and tailor that for the individual.
Yeah, I mean, the geriatric approach is really underrepresented. There's not enough geriatricians, and it's hard to get people to go into the field. We're having that problem in Singapore. It's true in the US as well. How do we redefine medicine a bit so more people are interested in the end of life?
Yeah, well, I mean, I think this is all the whole ageism thing. We think that the best part of life is being young and innovative, when in fact innovation doesn't change as you get older. You maintain your innovation, and so we stereotype people, and we think, oh, why would you want to be a doctor for those frail older people who are just going to complain about things? It's just the way we frame it. It's not the way they are. And I think the whole field of geroscience, the work you're doing on healthy longevity, that sort of stuff, that to me is the really exciting part of medicine at this point in time. And if people start to understand that, then maybe we can make it more attractive. I think we might have to remunerate them a bit better too, but you don't get paid as much as a geriatrician as if you're an orthopedic surgeon.
I'm going to have to remunerate you for that comment, actually. So let's talk a little bit about ageism. I mean, are there areas of the world that are handling this well. I mean, I think that, I look at things like forced retirement, and you compare that to the research which says that if people stay active and engaged, and if they enjoy their job, if they continue working, they're probably better off. How do we reconfigure policy toward people as they get older so that it's conducive to them being healthy longer?
Well, I think it's actually a win-win if people stay in the workforce, because not only is it better for the individual, it's better for the work environment. There's evidence that multi-generational teams deliver better than single-generation teams, and it's certainly better for the economy because people can continue to contribute through participation in the formal workforce. But again, we tend to have these stereotypes that say that older people are less productive, less creative, and the evidence is against them. I mean, the most successful entrepreneurs in the United States aren't young people. The most successful entrepreneurs on average are people over the age of 50, because even though there are some negative changes which occur with aging, and even cognitive changes that occur with aging, the experience and wisdom that aging gives people gives them other ways of contributing. But the problem, I think, is we tend to think of all this in a very rigid way. So we had mandatory retirement ages, and it's all or nothing. You're in or you're out. And we don't think of transitions in and transitions out. Many older people don't want to keep working at the same level. They want more flexibility. They'd like to start working part-time or things like that. But we generally have very rigid work environments, which makes it hard to achieve that. So I think we need to be thinking much more flexibly about how work can be delivered, the different role that people have. But also, on the other hand, people as they age need to also not hold so rigidly to the idea, I have to just climb the ladder and keep climbing it. Maybe you want to go down and, work part-time, have a better work-life balance. You can't expect to get paid the same if you're going to do that, though. So, I think it just takes a complete reframing, both for potential employers, but also for older people themselves.
We talk a lot about Singapore over some of these shows, and I spend a lot of time disparaging the United States. How's Australia doing in this?
Probably average. I mean, I hardly get back to Australia these days, but I think it's interesting that if we're looking to achieve this, we have to reframe health services with a much greater focus on primary care, and trying to think about how we can prevent disease, yes, but also maintain functioning. I think Australia does okay in the balance between primary and secondary care and the focus on prevention. It does as well as most places. It's not brilliant. We could all do a lot better, I think.
I was interested in your data from the study, the China study and the England study, and you talked about how similar their outcomes were. I'm wondering if there were any key differences. And one thing that comes to mind is, this different attitude of who makes decisions as you get older. It's perceived, maybe it's not real. The thought is in the West, that, as you said, people want to make their decisions for themselves. And my parents certainly fall into that category. But in Asia, you have the younger generation making more decisions for their parents as they get older. And I wondered if that's reflected anywhere in the data, or if you even think that's true.
Well, it wasn't in our data because we were looking at more the physical and mental level things that make up capacity. But I think it's an interesting point. You worded it as younger people in Asia want to make the decisions. I wonder if we asked older people what they want, the older people in Asia. And, I know there's this traditional attitude of filial piety, and but it's changing a lot. I mean, for example, in China, often generations no longer live together. So you can't show filial piety by, having your parents at home. And most younger people don't want that anymore. And most older people don't want to live with their kids anymore. So there's different ways of making sure that younger generations can ensure older people live, lives of meaning and dignity. So I think that's changing. And maybe at the same time, people's thinking about this is changing. But yeah, we didn't look at those questions. I think they're important ones. I mean, perhaps more interesting, and we've started looking at this, is physical aging in Asia happening the same as it has in Europe and the United States? And so we've looked at cohort trends over time within Elsa and Charles to see whether the people have better trends today than people previous generations had at the same age. And in fact, it does look like, particularly in Elsa, that people are aging better, particularly around cognitive capacity. The other ones, yes, maybe not quite so strong. It wasn't so obvious in China, which is interesting, but we're just doing the analysis at the moment. But I think that is really interesting, especially when you look at all the socio-demographic changes that occurred in Europe and that occurred in China around the 50s, 60s, when the people we're now looking at were growing up. You know, in China, you had the Cultural Revolution, for example, and what impact did that have on people's aging? I think that will be really interesting.
Yeah, I agree. And I think that one other thing that struck me, you know, you mentioned that, and I see this too, people say they're healthy when they actually have a lot of different conditions. And that brings up the idea of mindset, you know, optimism versus depression and pessimism. And is there anywhere that people have really looked at that? What is the effect of optimism on capacity?
Yeah. There are clearly some effects of personality traits. It's not my area of expertise, but we know, for example, yes, optimism seems to, you know, if you have a positive outlook, and this may relate back to what I also spoke about in terms of people internalizing ageist attitudes in a negative way. Oh my God, I'm getting old now. Life is just misery, and you know, I wish I was young, and you know, all that sort of thinking. Or people think, well, you know, this is not what I expected. This is the best time of my life, and getting out there. And those things have a very big impact on people's health. I haven't got the data, but in fact, those sorts of personality traits, to me, are part of the individual, and they should be inside this construct of intrinsic capacity. We just weren't able to test them.
Yeah, I feel like, and I have no data either, but I feel like people tend to polarize as they get older. They go down one of those two paths, and it seems like there's big influence on health there. So
yeah, absolutely.
Well, maybe what I'll do is I'll bring Sangeeta in to ask some questions from the audience, and let me just say that she's a trooper because she got tested positive for COVID today, and she's still doing the show. So that's how motivated she is to make things work. So thanks a lot for coming on tonight.
Thank you, Prof. Ryan. So thank you, Prof. John, for the very good presentation earlier. So we have a couple of questions from the floor. The first question is going to be, currently, are there any countries you believe are doing a good job in preparing for the socioeconomic impacts and opportunities of an aging population that could be modeled upon?
Okay, well, I mean, I think Japan is doing pretty well. Japan is at the forefront of population aging and is putting in place a whole lot of social as well as health and social care service type interventions. Actually, Singapore is doing a great job. I'm working with the Singapore Health District Project, and it's been really exciting to see some of the things that are happening in your own town. I don't think any country does it all perfectly, but there are a number of countries that have put in place a mixture of universal health coverage and long-term care. So I think there's 7 countries in the world which have mandatory long-term care insurance, which ensures no matter what happens to you, you can continue to have a life of meaning and dignity. So they're the Netherlands, Germany, Israel, Japan, South Korea, and I've missed a couple. So, I mean,
your cognition is hanging in there. So,
sorry?
That's pretty good, though. Your cognition is hanging in there.
Yeah, was that a test? No. Yeah, so I think it's varied. Generally, the countries which have had more socioeconomic development are doing a better job because they can afford to, but also socioeconomic development tends to go alongside population aging. So they also tend to be older, have older populations, and so it's more appropriate that that's where they spend their resources. But in making those investments, it's really important, and this is what I continually try to get across to decision makers, that that's an investment that you would want a return on, and the return on that is, yes, well-being of older people, but also they can contribute and participate and continue to do that to much older ages than that they otherwise would. And that's not necessarily just in the formal workforce. It's as caregivers, as advisors, mentors, through tax and so on.
Mm-hmm.
There's a lot of countries that are not as affluent and, haven't traditionally had as many people in the over 65 demographic. What is the WHO thought on aging in those populations? Because the change in many of those populations is much more rapid than it happened, in the more developed countries. So were there specific recommendations for what countries that are newly facing these challenges should do?
Yeah, I think the advice is to think about these things and act on them early rather than late. And so, for example, if you think about health systems, a lot of those countries which you're talking about have only really are only in the early stages of developing a comprehensive health system. The system that they develop will be really important in 20 or 30 years' time because we know what they're going to face. And if they develop, for example, fee-for-service, disease-based systems, they're going to end up with all these problems I was talking about earlier of care that's really, there's no continuity of care, no integration of care. And you actually have provider-driven care rather than care that's driven by the need of the person. So what the advice is to really think forward in terms of the systems you're creating now. It doesn't cost much to put in place a good system now, and it will save you a lot of investment as time goes by. Similarly, with long-term care and pensions, for example, financial security is really important in enabling older people to do all the things which we talk about and to receive health and social care. And so that, because there's not many older people, they can afford to put in place a pension system, and then just year by year, it just incrementally increases without a big impact on finances. So it's much better to think early rather than late. And then the other is not just to think about the systems that have been developed in other places, but to think about things that are appropriate in that setting. And so I've been doing some work in Cambodia, and I've previously worked with a group called Help Age in Vietnam and other places. And they have developed these things called older people's associations or intergenerational self-help groups, which are basically a community development initiative that brings together older people and sometimes other generations within local poor communities, and to try and support other older people in those communities. And so people participate while they're robust, because they know that when they need help, that same system is going to support them, and you end up with a wonderful system that can provide care. It often provides microcredits that enable older people to develop businesses and become more financially stable. And that's a totally different way of thinking about things than the traditional way in the West. And so I think the WHO would encourage that sort of lateral thinking rather than just trying to model things on what was done in the United States, for example.
Yeah, I recommend that too. So Geetha, do you have other questions?
Yeah. So the next question would be, rather than frame care as reactive to an oncoming disease state, should we not frame care as proactive to maintaining or promoting operating at peak or near performance?
Exactly, and I guess that's what I was trying to suggest, that at the moment we wait till people get diseases and then we try and manage them. Or at best, we try and focus on standard risk factors, particularly for cardiovascular disease, so physical activity, nutrition, not smoking, that sort of stuff. What I think we would be moving to is if we can monitor people's functioning much earlier in life, starting in midlife, then we can start thinking about, well, what are the interventions that actually help people maintain the best possible functioning? And if you think about it, those early trajectories in midlife are probably more important than what's happening later. Later, it's probably too late. But by just subtly changing a trajectory, we should be able to really create much more benefits down the track. And again, if we can monitor people's health directly at that time, we might be able to find interventions which we're not even thinking about at the moment. Or we might be able to say, well, this intervention, this form of physical activity is right for people with this genetic inheritance. This one is right for people with other circumstances in terms of functioning and genes, and personalize much more our advice. So, at the moment we give generic advice to prevent a handful of diseases. We don't give people any feedback beyond how many steps a day they're doing. I mean, okay, I'm doing 10,000 steps a day. How's that helping my health? I don't know.
Yeah.
So whereas if I think the way we're thinking about things, if we can give people instant feedback in terms of, well, this change exercise you've been doing for the last 3 months has really changed your trajectory of health, then I think that feedback will help them sort of think differently about their lives as well. So absolutely, let's think much earlier about what we're doing, and let's not sort of frame it through limit our framing of it through specific diseases. Let's think much more about how we can monitor that and give people feedback.
Okay, so we have one more question. So with regard to attending to the declining functional capacity at the level of care of the individual healthcare recipient, if one is just looking at decline rather than thresholds for disease diagnosis, how do you envision thresholds for intervention? Do you have more specific examples of managing health in terms of functional capacity at the level of practical consult room encounters or institution organization?
Okay. Thresholds it's interesting. When we worked on developing the Integrated Care for Older People program at WHO, this came up repeatedly because clinicians really require thresholds, because you treat somebody when they meet these criteria. You provide this. That's a traditional way of thinking. People meet these clinical criteria, you do this intervention, and people who don't meet that criteria, they don't get the intervention. But that's a very artificial way of thinking about health. If you think of it as a continuum, then there are no thresholds. We can use thresholds for labeling people, but in terms of the interventions, what we'd be looking at is changing the trajectory. And those trajectories, maybe we need thresholds for what the trajectory, how much it has to veer off the norm. But I think, just as you see that somebody is below the population norm, or the trajectory is worse than the population norm, you start thinking about what you can do to change that. And so let me give you the example of the Integrated Care for Older People program, and it's on the web if people want to look it up. And there's an app to help people through it, and there's also clinical pathways which show how this is done. We in that program, we started with a screening instrument, which is just 5 very simple things. A quick test of word recall. Can people hear? Get them to do a chair rise test, how many times they can get off a chair in 15 seconds. And if all of that's okay, you just give them generic advice. If one of them screened badly, then you start delving down and doing a more detailed assessment. And in that assessment, you say, "Well, this person really is declining on cognitive function." And then you start looking at, okay, why might that be happening? And obviously, you would try to exclude something like like Alzheimer's disease. But by starting from the fact that they've got the decline, you think of all the other things which might be influencing it. And so, it might be some of the cardiovascular risk factors. They're high on them, and perhaps they're getting some vascular dementia. Anyway, there's all sorts of other causes of loss of cognitive function, loss of locomotor capacity, than just the traditional diseases we think of. And you can create quite clear clinical pathways to help a clinician or an individual navigate through that assessment, and then provide an integrated response, which ideally would be developed in association with the person themselves to ask them, well, what is it that you actually are trying to achieve? Where do you want to be? What do you want? What do you need to do? And how do we frame this in a way that's right for you? And at the same time, also thinking about their personalized characteristics and the way that might influence the interventions which we deliver and make them work more effectively or less effectively.
You know, I think one of the challenges with that, which is great, I think it's a great approach. One of the challenges with it is time. You know, the doctors have so little time with patients, and you know, maybe we need to train a different set of people to go through this. I think that in Singapore, you know, the primary care doctors have 6-7 minutes a lot of times with each patient, and all of this gets missed when it may be the most important thing they could be talking to them about.
No, exactly. You could get somebody screening them before they actually see the doctor, so the results are there in front of them, and there's sort of perhaps a draft clinical pathway there, and then the doctor interprets it and decides, you know, how to move forward. No, exactly. But again, we need to stop thinking so rigidly, not just about the diseases and the professional silos, but also these hierarchical systems where a doctor does something, a nurse does something, somebody else does something else. We need to reinvent the whole thing.
Yeah, I agree. Well, thanks a lot, John, for joining us. This was a great conversation, and thanks, Sangeetha. Get better.
Thank you.
I want to remind everyone to use the chat function and the panelists and all attendees option to leave comments and feedbacks on the show. Also, look in the credits for news for our Center for Healthy Longevity and the School of Medicine. For those of you who need more discussion on aging, we have a Twitter account. You're welcome to go to that. The link is in the chat box, or you can scan the QR code, which will appear at the end of the webinar. We've also recently launched our Center for Healthy Longevity website under the NUHS Centers of Excellence. So if you'd like to know more about what we're doing specifically in Singapore, you can go to that site and read some of the material. You can also look at some of the clinical studies going on and maybe even sign up. Our next show will be June 9th, and we'll have Professor Arfan Ikram on. The host will be Andrea, who will finally be back from Suriname. And our final video today is from a radio station, Power 98, that features a senior commando who's still keeping up those training habits. Thanks a lot for joining us.
Every day, I either do a 10-kilometer run with 5 sets of Dapata, or I do a 10 set of Dapata with a 5-kilometer run, ended with 1,000 crunches. Workout is to get healthy, relate to fitness, you will get younger and younger.
Sorry, 1,000 crunches?
Yep, every day. After my workout, I will complete with 1,000 crunches.
I'm feeling like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down.